Hi, Rich. Thank you once again for having me here. Hi, Bancha.
Hi.
To you. Thanks for being here.
And thank you, Dr. Bancha. Thank you.
Bancha's so busy.
That's right. That's right.
Sorry.
I mean, these have been excellent talks, and really, multi-ligament injuries are a very challenging problem, and I really value the expertise that's been shared here. I think really this is a great opportunity to sort of ask the first question. There was one question that was raised in the chat earlier. It was actually for Dr. Bhatt, but I don't think he's actually here.
Raj, I think Umar is right here now.
Is he?
Wait, we'll ask him to be placed in the panel.
Mhm.
Okay, maybe while we're waiting for him to get on, maybe let me start with a question for Bancha.
Yeah.
Very challenging cases you shared. Congratulations. Very good work.
Yeah, thank you.
Have you had issues with tunnel coalescence, particularly when you're combining cruciate and collateral ligament reconstructions?
Right.
At the same time? Yeah.
So that's the problem, We need to do really good design, how to deal with that. Sometimes you need to draw in the paper, that where's your tunnel, and in the situations that you need to deal with like 4 ligaments. Sometimes I put my scope into the tunnel, when I drill the tunnel, and make sure that the tunnel is not jamming. That's the problem.
All right.
But
Good.
most of the time we do it like stage reconstruction, large. We do like chronic injury, chronic instability. I start with cruciate first, right, and collateral, and most of the time I follow after that I do ACL reconstruction later. For acute situation, I manage the corner first, the collateral, and followed by ACL and PCL later.
Thank you. Is Umar here or?
Well, wait, he's having problems entering.
Okay, no problem, no worries. Dr. Bancha, thank you very much for your talk. I learned a lot. I just wanted to ask you, particularly in your acute injuries, in patients who come in with acute combined PCL and ACL injuries, what is your timing of surgery? How early do you go in to do the reconstruction?
Thank you. It's a good question, actually. For acute injuries, there's no collateral injury. If we assume that ACL and PCL both are gone. So it's my timing is around, after the injury, around 1 week. Not wait 2 weeks, 3 weeks. I just want to keep the knee next to the normal. Edema, swelling, hematoma, or the pain should be gone a little bit, but not totally. Just wait only 1 week, maybe. If the knee is close to normal range of motion and less edema or pain, I just do the reconstruction at the same time. Not wait too long.
And in terms of your rehabilitation, you keep them, traditionally we have talked about keeping patients with PCL reconstruction are not weight bearing. What is your
okay, I follow the PCL rehabilitation protocol after both tendons are reconstructed, because we don't have any problem with the ACL weight bearing and so on. So I don't let them weight bear after ACL and PCL reconstruction like 6 weeks without weight bearing, but try to gain full range of motion in one month, but not to sag the knee downwards. I do range of motion in prone position, in prone. Yeah.
Thank you.
Thank you.
Okay, I guess we'll wait a little bit longer for Umar. But just to recap, particularly with your acute injuries, I like the way you sort of had that algorithm in terms of what you deal with. So you talked about dealing with the corners first.
Right.
So particularly when they're bony avulsions, you would sort of fix
Right.
them.
In acute situations, I do manage the bony avulsion, bucket handle, or lock meniscus. We need to manage. Also, condyle
Right.
fracture. Yeah.
Okay.
So we need to do that. Or quadriceps tendons or patellar tendon rupture, we need to manage. And then collateral ligament.
Hello.
Yeah, that my approach. Because if you do it later, it's not easy. Like you let the chronic bucket handle and you come back again 3 months, you cannot reduce it. Yeah. So that's my approach for the first 3 weeks. But my perfect time for me is around same like Osensi, is about 10 days. Yeah, because you can do very easy repair and everything, right?
And when would you? And then when would you do your cruciates? After how long would you do your cruciate reconstructions after this, the acute repairs? Yeah. Prof.Bancha, then it's after you've done your fixations, your bony avulsion fixations. How long after that will you come back to do your cruciate reconstruction?
Or cruciate reconstruction.
Yeah.
I wait. I think after 6 weeks, around 3 months after the patient have good motions. Yeah, and come back for the cruciate reconstruction later.
All right. Thank you. Hi, Umar. Thank you for joining us. Excellent.
So sorry, I was traveling all night from Karachi and I just came back very late, around 2 a.m. and I slept for 2 hours and it's just been not an easy journey.
Oh, dear.
So apologize.
No worries. Thank you for your talk. And thank you for being here. There was a question earlier.
Material doesn't make any difference in the outcome. It's the principle that makes. You can use a hamstring tendon, you can use a fiber tape, you can use double tape. The whole purpose, which I tried to explain, was to reduce the volume of the capsule. A lot of people sometimes mislead themselves that actually it's the MCL that leads to residual laxity. It's not the MCL. Interestingly, when you scope a patient during ACL reconstruction, and if they have an MCL tear, and if you move your knee into a valgus position, you will note that the knee actually opens up quite a lot, even though MCL is intact. So sometimes capsular laxity and this residual capsular laxity reduces the length of the MCL. And that is the reason, in order to reduce that length and allow the MCL to heal in its original anatomical position, an internal brace is much easier. It's faster rehab, patient go home quicker, you don't have to do any brace. And I felt that that this is the whole principle behind bringing the kinematics of the knee back into its normality. And rather than doing a very big incision and repairing the MCL, or in case leaving it alone, which a lot of people has got controversial, why not just putting a 2-stab incision, putting an internal brace, use either swivel lock, use whatever anchor you want. I don't think so anchor makes any difference. It's the principle which makes the difference, and it does a good job. So it doesn't need to be removed. It stays in, and you can use any material available, either Arthrex with an FU, whatever fiber tape you have.
So this would be in addition to, I suppose, the primary suture ankle repair of the avulsion of the MCL.
Yeah, avulsion is a different ball game. If you are talking about an avulsion, obviously that needs to be properly repaired. I was talking about a combined ACL MCL injury in which you can clearly see when you open up the knee joint, it's between grade 2. Sometimes you feel it's grade 1. When you reconstruct the ACL, you still feel a slight laxity. Oh, I can leave it alone in a hinge knee brace, let it be. No. When I see like that, I just put a straight away internal brace. And I saw 6 weeks result post-op, which I show on the video demonstration. They do very well. And I never used to do them. Trust me. It's just, I think 2 years ago, I started feeling in my part of the world that especially young guys, when they're playing football, they do have quite a lot of MCL injury, not grade 3, sometime between grade 2 and 1. And post-op, post-ACL reconstruction, before I would put the final screw, I just again examine it under tension. And I feel if there is a laxity, I just put an internal brace.
I believe Bancha has a reaction to that. Yes, go ahead, Bancha.
So I have experience with the MCL internal brace. It's very stable, but that patient has some stiffness. Yeah, so I need to come back to cut the internal brace 3 months later.
Hmm.
Yeah, you have that experience?
No, Bancha, you a very good question. They will have stiffness. I try to keep a bit loose. I don't keep them over tight.
Oh, really?
I would do the other. I would leave them a bit lax rather than making them very stiff. Tiny bit laxity. So around 2-3 millimeter of play.
Yeah.
In especially in 30-degree, not in full extension, maybe one degree, but in 3-degree, I would keep, because once you put the suture, close the wound, put them in a hinge knee brace for a week, everything becomes tight, and I fully agree. So you shouldn't over tight them.
Yeah.
So I think yes, I haven't done. I would be honest, I haven't done in huge numbers, maybe 10, 12,
Yeah.
and so far I've been lucky. I've been lucky.
Yeah, thank you.
Thank you.
So yeah,
Yes,
in
sorry.
that scenario, Dr. Umar, when you do put the vibra tape, you don't put the knee into virus anymore. So just leave it as it is, just so that you don't over tighten your vibra tape.
No. Absolutely not. No, I would never do that.
Okay.
Thank you. There was one question that came up for Bancha. What would be your approach to tibial tattoo fractures with associated meniscal tears?
What is, excuse me?
What would be your approach to tibial tattoo fractures that are associated with meniscal tears? It's quite a challenging situation.
Tibial plateau, right?
Yeah,
But
tibial plateau plus meniscal tears.
Actually, I didn't do that myself. The fracture I sent to the trauma guys. Yeah. So I have no good answer for that. I have less experience. Someone can answer that for me?
But have you received referrals, Bancha, after they've done fixation of the tibial plateau fractures? They're subsequently referred to you because of a meniscus tear?
You mean after the fracture heal, right?
Yes.
Okay. So
I think
if the fracture heal in a good alignment, that's okay. So I come back to manage the meniscus. Yeah, by repair or I have one patient that have a root avulsion in plateau fracture. I do the root reconstruction because of a very big gap. Yeah.
So, yes.
Yes, please.
So where I work in Karachi, it's the major trauma center. We deal with very complex trauma, just like any other part, like in India and Pakistan. You know, the trauma level is extremely high. So we see every day massive tibial plateau fracture. And my friend Imran Shah is a very good trauma surgeon. Does a lot of trauma of tibial plateau. So we do combined surgery together. So he will open up the knee joint, and if he can see, because we operate together next to each other, so if we plan ahead, we do an MRI scan and CT, and we know that the intraarticular, there are multiple fragments, so he will do a very nice reduction, and the knee joint is opened up. I would do open repair. And I have done many times, because the knee is opened, I can see that the whole meniscus has flipped. There is no reason why we should not do open repairs. My personality has transformed in the last 5 years working in this part of the world when I see this type of complex injury in which knee joint has opened up. And you can see in front of you, there is a condyle, there is a meniscus flipping around. Just bring it back, use a nice Vicryl and do a standard old school style repair, and they do very well. And then close the wound, early mobilization. So it all depends that if it's a small tibial plateau fracture, fine, but if it's a massive one with literally pieces, then when you're opening up the knee joint, you see everything in front of you. So it's much better to do another bigger incision just on top, close to the mid patella, see the knee. You see the meniscus, just gently open the knee joint, and sometimes we avert the patella, just like we do a total knee replacement. You see everything. I always felt that opening up the knee joint in young guys is a bad idea, but in a right indication, opening up is not a bad idea at all. There is no problem if you close the wound nicely, you respect the anatomy, you mobilize them early. Yes, the scar is big, but they do very well. Only in a specific indication.
Thank you.
Yeah, if I may throw just one last question to the panel before we close this session. We've all talked about multiligament injuries, so we'd now like to get your opinion. There's, of course, this ongoing controversy with regard to the sequence of tensioning and sequence of fixation if you're doing both the ACL and PCL reconstructions. So you did present sort of differing opinions, differing sequences, differing ways and positions of the knee at which you'd actually do your tensioning and fixation. So can you give us briefly again your protocols with regard to if you have a combined ACL and PCL reconstruction, what's the sequence of tensioning and why, and what's your sequence of fixation and why?
Is this question for me?
For everyone,
Everyone.
for all three. So let's probably start with Professor Murtagh.
Okay, thank you. If both ligaments to be reconstructed, ACL and PCL, I always start with PCL, as Bancha told that this is the primary ligament to be reconstructed always. So I start with PCL. I fix femoral side of PCL first, then I fix femoral side of ACL second, then I fix tibial side of PCL in 90 degrees of flexion. Third, then fourth, I fix the tibial side of ACL in 20-30 degrees of extension. That's my steps. I always follow these steps.
Yeah. For me,
Dr. Umar?
it's the
Uh,
yeah. You first.
Please, Bancha, go ahead.
Bancha, yeah, go ahead.
Okay,
Bancha.
I used to fix my PCL first. Yeah. But I found that after fixing the PCL, there's some subluxation. So now I change. I fix my ACL first at 0 degree because anyway you need to fix your ACL like you have native ACL, right, at 0 degree. And after that, I bend the knee to 90 degree to fix my PCL. Yeah, and I found that the result and subluxation is less using this technique. Let's think like you have isolated PCL injury. You fix your ACL first to make it like native ACL, and then you do 90 degree anterior drawer to fix your PCL. So that's my approach. And for the collateral, I fix my popliteus at 60 degree of neutral rotation, my LCL at 30 degree of neutral rotation, also the MCL. So that's my approach.
Dr. Umar?
If you look at the knee joint, when you see an isolated PCL injury and you put a scope in extension, you will see that the ACL always remains quite tight. Or when you look at the partial ACL tear, because if you come across perception and you have changed your personality of approaching ACL as a repair, you will notice that in some cases, when you keep the knee in slight extension, ACL looks nice and tight. As soon as you bring the knee into 90 degree and you put the probe on the ACL, I'm talking about ACL, not PCL, you will see it's a bit loose. Now let's do the same thing about PCL. ACL is intact and PCL is injured. You put the knee at 90 degree, you will notice that at 90 degree, the ACL looks very loose. So if you bring the knee forward during arthroscopy, you will notice that the ACL looks very tight. So my principle is quite close to Murtagh. So I would do femoral fixation of PCL and ACL. I will bring the knee at 90 degree and I would always use a pen test. Sometime I think history teaches us good lesson. You keep the knee at 90 degree and you look at the pen test to see how the knee is forwarded further. Remember one thing, couple of patients, if you do the contralateral side examination, you will have a very good judgment that how much their tibia is subluxed forwardly in an intact ACL. So you have a comparison before you start the surgery. And if you know that there is 5 millimeter tibia translated forward, so you translate the tibia maximum forward and fix the PCL in that direction because that's the normal anatomical position of that gentleman's knee. And I would fix ACL exactly in the same position. I won't move the knee at all. So I would keep the knee in the same position, which I fixed the PCL, and I would then tighten up my final ACL. And then I will take it through the range of movement. Because if you look at the knee at a 90 degree, you will see how much the knee has translated forward in a normal intact knee of that gentleman, which has got injury on left side, and you're examining the right side. So I think there are many ways to skin the cat, but it's individual preference, experience that comes into play. My choice is like that, just like Murtagh mentioned. But I agree with Bancha as well that if it's in his hand, that's the principle, then one should follow that, should not change.
Yeah, right.
So I guess that's still going to be an ongoing debate, and it will probably be a debate that will stay with us as with other orthopedic procedures as well.
Thank you. Just one last question in the chat.
Recording stopped.
Oops. Okay, and basically it's from Timothy. So this question was
Recording in progress.
after fixing the PCL, when you do a posterior, do you do a posterior draw when you fix the ACL on the tibial side? Maybe I ask Dr. Bancha. So when you actually you've done your PCL fixation, PCL tibial fixation with the knee 90.
Yes, I understand. I don't do that.
Okay.
Because as Umar underlined, when I fix the PCL, I assume that I fix it in normal position.
Yeah.
And then when I fix the ACL, it should be a little bit the tibia should be a little bit anterior to the femur, so as in normal position. If I push it backwards, it means that you're fixing ACL loose. It's gonna be loose. So I don't do that.
Thank you. Yeah, I agree. Great. Otherwise, I think we've had an excellent session. I'd like to thank the speakers for wonderful talks. I certainly learned a lot, and also my fellow moderators, Tony and Rich. Thank you very much. And congratulations once again on an excellent conference. Thank you.
Thanks, guys. Thanks, Murther.
Thank you. Thank you very much.
Thank you. Thank you, Murther,
Bye.
Umar, Bancha.
Thank you.
Bye.
See you guys.
Okay, so I think we go proceed now to the meniscal talk.